I start off with a recent social media controversy. I'm not a very great fan of social media, but there was a doctors group in which a lot of talks went on, and the theme of the talk was that the heart attacks occur in spite of statins, and people said that cholesterol hypothesis is a myth and industry generated, and statins are the cause of diabetic epidemic in India, and heart attacks occur in spite of no risk factors. Some of them are partially true, some of them are blatantly wrong, but the important thing is that heart attacks do occur without risk factors. About 20% of heart attacks patients do not have any risk factors, and about half of patients with heart attacks, their cholesterol levels are normal or even low. So there is something more than just cholesterol in a heart attack. And another important thing is that we all know about the cardiovascular epidemic, and the cardiovascular disease is the number one cause of death all over the world, in India also, and also in Chennai. So most of us are going to die of a cardiovascular disease. That includes me. And most of our patients, most of our relatives, friends are going to die of a cardiovascular disease. So it is for our own interest that we keep updated about what's happening in the cardiovascular disease front. And this is an important slide by Dr. Peter Libby. And when the common thinking not even among laypersons but also among doctors, is that if the angiogram doesn't show any critical block, you're safe. And it's only the critical blocks which produce heart attacks. But actually it is not true. Majority of the heart attacks are produced by non-critical blocks or vulnerable plaques. And you need not have this kind of flow limiting stenosis to have a heart attack. And how does heart attack occur? There is a plaque here, and which contains cholesterol or lipids. It has got a fibrous cap, and fibrous cap has got a thin shoulder, and the thin shoulder ruptures. The cholesterol gets exposed to the blood. It is thrombogenic, and it causes a heart attack. So that is how most of us are going to meet our maker. But is it just a thin fibrous cap which ruptures? There are a lot of challenges to the vulnerable plaque concept. Many so-called thin cap atheromas do not rupture. If you do intravascular imaging, you find that even a patient with heart attack, there will be many very high risk thin cap fibroatheromas which never rupture. And it's a focal thing. Systemic disease having focality of atheroma formation and thrombotic complication in time and space is currently difficult to explain. Risk factors are systemic, but why do vulnerable plaques form locally? And atheromas take years to form. And what causes something at that particular moment? What causes the heart attack at this particular time? And can targeted anti-inflammatory therapy reduce coronary events? And another important concept is of residual risk. We think that we are getting the best treatment. Somebody must have got high dose statins, maybe angiogram, angioplasty, but still a significant amount of risk remains. All these will reduce the risk by about 40 to 50%, but 50 to 60% of the people still carry risk for cardiovascular disease. So some of you would have heard about cardiovascular continuum, some of you would have heard about cardiorenal continuum, but there also is an inflammatory continuum in atherosclerosis. Atherosclerosis is precipitated or started, the fatty streaks form, and all of us for sure are carrying fatty streaks, and it's started by low-grade inflammation, and it becomes high amplitude inflammation, and the plaque ruptures, you get a heart attack, and after getting a heart attack, there can be the healing and different kinds of healing, and that also myocardial damage and myocardial repair is also mediated by inflammation. So it takes two to tango. So we all thought that cholesterol was the sole culprit. Now we know that cholesterol and inflammation are partners, and seeing the picture, everybody's eyes will be on the pretty girl. Similarly, everybody's focus is on cholesterol, but inflammation is also an equally culpable partner. So I will divide my talk into 3 time frames: 1995 2002, 2002 to 2008, and 2009 to current, and different aspects of inflammation in this time period. In the first time, the people are looking at whether the high inflammatory markers can correlate with vascular risk. Higher inflammatory markers, can there be increased cardiovascular risk? Then they proved it. Then they went on to see whether treating it could reduce cardiac events, and treating it at that time statins who are kind of not eligible for statins or no need for statins but still high CRP, whether they benefited. And then finally now focal focused anti-inflammatories, whether they benefit. HSCRP, high sensitivity CRP, is the best studied marker. It independently predicts the risk of future MI, stroke and sudden death even when LDL is low. We see many patients who have perfectly beautiful lipid profile, low risk factors. They sometimes are very obsessive. They would have taken a CT angio. Sometimes they'll have typical pains, and we do a CT angio or maybe even cath, and then they look near normal and tell them everything is fine. But in actuality, everything may not be fine. The inflammation reflects a component of vascular risk different from lipids, and addition of HSCRP to other risk factors increases our pickup of high risk patients. The values considered less than 1 is low, 1 to 3 is moderate, and more than 3 is high risk, and more than 10 indicates that they have a systemic inflammation or even a caries tooth, and more than 10 is not considered. What is now accepted is screening for HSCRP is not mandatory but should be done at the discretion of physicians for global risk evaluation. And another important thing is HSCRP doesn't correlate with the atherosclerotic disease, the actual cholesterol there. And it does not simply reflect the presence of an underlying disease, but indicates a higher likelihood for plaque rupture. So plaque rupture is what the event which drives the heart attack. So HSCRP is an indicator for plaque rupture. Another important thing is HSCRP is a predictor for diabetes in those with or without insulin resistance and correlates with multiple components of metabolic syndrome. Diabetes is now called an inflammatory disease, and it's some people call it a less endocrine and more inflammatory disease. So here in this slide you can see that higher the CRP, the higher risk of heart attacks or strokes, no problems there. What about aspirin? We know we all give aspirin for coronary artery disease, but the maximum benefit is in people who have high HSCRP, because aspirin is also an anti-inflammatory in smaller doses also. Another important factor is this is cholesterol, this is HSCRP. We all know that lower the cholesterol, better, and now we are driving the cholesterol down. We think that to drive it around 45 or 50 may be better. Newer guidelines may indicate lower, still lower, but we look at HSCRP, it is almost parallels the LDL. So we know that LDL is a bad, but we don't think HSCRP, we don't consider that much. And again, this is an important slide. I think if we have one take-home message, this will be the take-home message, because this is the risk for coronary artery disease. And look at blood pressure, total cholesterol, and non-HDL. There have been tons of talks, many talks. Everyone would have attended talks, lectures on blood pressure, total cholesterol, and non-HDL. It's the flavor of the month. And all these as risk factor for CAD. But look at HSCRP. Actually, this is published in Lancet, and here the risk factor is much more than even non-HDL cholesterol. And the Reynolds index of risk scoring has included HSCRP and family history, and Reynolds index has been accepted that it is better than Framingham risk score. And another important interesting slide is that many prescribe statins. Some of us may be taking statins, but here it has been shown that in this pravastatin, this study, the people who took pravastatin, the benefit was in patients who had high CRP, whereas there was no inflammation inflammation was absent, statins were as good as placebo. Now we come to second part, where that is basically driven by Jupiter trial. Like for the non-cardiologist, the Jupiter trial was a landmark trial, and what they found was in patients with no prior heart disease or diabetes, an LDL less than 130, but with hsCRP more than 2. That means at that time, these patients were not required to have statins or no need for statins. Even now the present guidelines, most of these patients will not need or will not be eligible for statins, but their CRP, they got high inflammatory markers, and whether it is statin had benefit, and there was fantastic benefit. P-value was less than 0.000001, and number needed to treat was only 25. This was stopped prematurely, and there was a whopping 44% reduction. 44% reduction in cardiac event. And this is across all risk factors, in low body weight, high body weight, metabolic syndrome, no metabolic syndrome. And the biggest problem with this trial was many people asked whether it is due to hsCRP reduction or cholesterol reduction. But if you see here, the maximum benefit was there in those with higher hsCRP. So this was the biggest problem, because it reduced LDL by 50%, hsCRP by around 40%, which produced what? And there was a lot of controversy. Many people even now think that hsCRP is a bystander. And there's some genetic studies to show that the genetic determinants of rosustatin-induced LDL cholesterol does not predict rosustatin-induced CRP reduction. They do not go parallelly. And again, it reduces venous thromboembolism. So there is, in the veins, there is no cholesterol deposition, only inflammation. So there is significant reduction in venous thromboembolism that also favors the inflammatory concept. Now we come to the third aspect of my talk, that is newer inflammatory pathways. People are divided inflammatory pathways in upstream targets and downstream targets. Upstream targets are vessel wall, macrophage, adipose tissue, and interleukins, tumor necrosis factors, etc., are the main players there. Downstream, it is CRP, PI1, and fibrinogen. And people think that it's upstream inflammatory markers which are more important. But how do you differentiate? Because problem is statins reduce cholesterol and also inflammatory markers. So whether it is due to cholesterol reduction or CRP reduction, nobody knew. In tumor necrosis inhibition, what happened was TNF inhibition and interleukin 6 inhibition, what happened was cholesterol actually increased. So that's also bad. And here this is low dose methotrexate and interleukin 1B inhibition, and there's no effect on cholesterol and inflammatory markers reduced. And those observational data show that patients who are on low dose methotrexate had reduced cardiovascular death. And the lab data show that methotrexate inhibits atherogenesis in cholesterol-fed rabbits with no change in cholesterol at all. So they had a trial, or the trial is ongoing. It's called a CART trial. It's interesting because not pharmaceutical industry driven, it is NHLBI driven. And that also, what they do is the patients with the previous MI plus either diabetes or metabolic syndrome, and they were randomized. And there was another arm to show whether this new onset of type 2 diabetes can be prevented in patients with metabolic syndrome. That is anti-inflammatory as a preventive aspect for diabetes. It has been said that in a jocular way, India is a country with very great diversity, and somebody has said that the Indians can be divided into many groups, but broadly Indians can be divided or considered as one group, that is, Indians can be considered as diabetics and potential diabetics or pre-diabetics. There is no Indians are all come under that category, and diabetes is the thing, not even cricket, that unifies all Indians. So this is about interleukin 1B inhibition, and interleukin 1 alpha and 1 beta are pro-inflammatory. Anything inhibiting it can produce anti-inflammatory action. And canakinumab is a drug, it's a monoclonal antibody to interleukin 1B. It has been approved for certain conditions like CAP syndrome and Muckle-Wells syndrome. So this study I am part of, and the recruitment is over. We do not know the results, but if it becomes positive, it's a major triumph for inflammatory hypothesis. And canakinumab reduced fibrinogen, interleukin-6, and CRP. That study is called CANTOS. There are many newer drugs by the youngsters here, and like infliximab has already been mentioned as treatment for inflammatory bowel diseases, but infliximab has been tried for the atherosclerosis also. But what has happened is lot of trials, busy slide, but most of the trials failed. So only thing going is CANTOS with canakinumab and low-dose methotrexate trials. What about older drugs like aspirin and salicylate? Salicylate is also called as salicylate. It is not acetylated. So the salicylate is not a cyclooxygenase inhibitor and does not impact upon bleeding times or platelet aggregation. It reduces HbA1c, reduces diabetes and CRP. It's got systemic anti-inflammatory effects. It's inexpensive and well tolerated. So people are looking into it. What about colchicine? Colchicine has been a major story here because the colchicine has got a lot of provocative data, and it has got anti-inflammatory properties. It reduces C-reactive protein independent of aspirin and statins, and chloroquine has been gone out of vogue. This is a study called LODOCO trial, which there is showed that there is a definite reduction in cardiovascular events. What about vaccination? This is the dream of the future. Dr. Shantaram exhorted the youngsters to dream, and there is a dream of vaccination against atherosclerosis and using LDL as immunogen. People have tried oxidized LDL as immunogen and peptide sequence of apolipoprotein B100 as an immunogen, and these are things of the future. Other things include sirtuin-1 and sirtuin downstream C-reactive protein antagonists. All of them are in the lab and animal trial levels. Another pathway is called kynurenine pathway that is active in the blood vessel, and 5-hydroxyanthranilic acid is an intermediate product of kynurenine pathway. It's a powerful inhibitor of atherosclerotic lesions, and 5-HAA significantly reduces vascular inflammation that still has to reach clinical trials, big clinical trials. Curcumin has been mentioned, and for me curcumin is of interest because a lot of studies are going on curcumin. It has been said to prevent dementia. Most of us are reaching the age of getting into dementia, so it said that curcumin can prevent dementia, and it's got multiple actions on the heart or the atherosclerosis. It reduces C-reactive protein, reduces MI, small studies, or reduces cholesterol and prevents progress of diabetic nephropathy, decrease fasting glucose, HbA1c and insulin resistant index. So this may be a wonder drug, but we have to actually work it out. So this is my three main points. There is the evidence that higher dose of inflammation correlates with the risk, yes. Reducing that, whether it reduces cardiovascular events, yes. But for targeted treatment, whether it's beneficial, let's find out. So there are many limitations. The limitation is that inflammatory system is simultaneously redundant, compensatory, and crucial for survival. So giving long-standing anti-inflammatory, whether it's beneficial, we do not know. So genetic studies and newer imaging technologies. People have tried specific PET scan imaging to see, okay, these are the guys with higher vascular inflammation, and these are the guys who require anti-inflammatory. Few slides about diabetes, because as I said before, we are all either diabetics or pre-diabetics or would-be diabetics, and in Indian especially we have huge amount of intra-abdominal adiposity, and this adipose tissue is one of the most active organs. A lot of anti-inflammatories get released, and what do they do? And all of us, including the thinnest persons here, will have very high intra-abdominal fat, and that leads on dyslipidemia, insulin resistance, and inflammation. So this partly answers my first slide. People said, okay, statins are bad. Statins do increase diabetes or blood sugars by about 10%. It is not 46%, which is a relative risk as in medicine trial. But it counters two aspects of this higher intra-abdominal adiposity, dyslipidemia and inflammation. So it has got benefit. And for every 255 patients treated with statins for 4 years, there will be one additional case of diabetes, but 5.4 less coronary events. So even in diabetics, even pre-diabetics, even primary prevention, even secondary prevention, the benefit of statins outweighs the diabetic risk of statin. So this is my penultimate slide. This is from Roberto Ferraro, who is the former president of European Society of Cardiology. And what he has said is, he has analyzed the ESC data and what has medicine done for people or longevity of people in this generation, last 30 to 40 years. And what has found is that 10 years of lifespan has been increased. And cardiology has contributed to 7 of these 10 years. That's not the main point. The main point is that 50% of the longevity or by cardiology is by lifestyle, that is exercise, diet, reducing tobacco. 40% is due to drugs, antiplatelets, beta blockers, ACE/ARBs and statins. Only 10% due to interventions, bypass and PTCA. Oncology has contributed only 2.4 months increase in life. But whether anti-inflammatory will get into this exalted pantheon of drugs, we do not know. I cannot predict now. And I will, for brevity and for fun, I will show this slide. The problems of prediction, these are all the worst predictions. In 1876, Western Union said that the telephone has too many shortcomings to be seriously considered as a means of communication. Thomas Watson, chairman of IBM in 1949, said, I think there is a world market for maybe only 5 computers. And in 1962, the Decca Records rejected the Beatles and said that we don't like the sound and we think that guitar music is on the way out. So the take-home messages are, the next decade will inform cardiologists or the cardiology as a whole whether driving the cholesterol down is the only treatment or anti-inflammatories also will have a place along with that. Atherosclerosis is a systemic disease in need of systemic therapies. And cardiology community can no longer simply address the mechanical reversal of coronary stenosis. This is my goodbye slide. This is from Bertrand Russell. The whole problem, this again in view of the initial, the social media storm, the whole problem with the world is that fools and fanatics are always so certain of themselves and wiser people so full of doubts. It's still doubtful that the role of anti-inflammatories, but we had to go forward. And thank you for patient hearing. This is Adrapalli, where Bahubali was shot. So like now it's beautiful in that place. With that, I conclude and thank you once again for patient hearing.